اليوم إن شاء الله راح نتكلم عن الديسمينوريا. We have two types. We have a primary and secondary. The primary one is basically عادة يصير there is a painful menses that is affecting the quality of life and associated with nausea and vomiting, and there is no pathology in the pelvis, okay? And usually this can be treated by non-steroid or combined oral contraceptive, all right? But in the case of secondary dysmenorrhea, there is a pathology that's causing this painful menses. We can do, we have adenomyosis, we have endometriosis, leiomyomas, and usually they will present with pain 2 to 3 days before the menses and during the first day of menses, and then subside. Now in primary dysmenorrhea, this all because of prostaglandin release from the necrotic tissue, okay? But it will be hyper released, and there is something wrong with it, right? Because in normal menses you will not have very painful spasmodic pain. Now the first one, today I will talk about endometriosis. In endometriosis, there is a very nice graphic here showing the summary of it. Let's start from the beginning. What is the main cause, or what is the pathogenesis? Now, first there is three theories. There is coelomic metaplasia. That means that the cells that is found in the peritoneum, they become differentiated into endometrial cells, okay? In disseminated theory, that means there is transportation of the endometrial tissue from the uterus to other areas through the blood and lymphatic. Now, implantation theory is the most important one. Now, if you have Asherman syndrome, or you have cervical stenosis, okay, or if you do hysterosalpingogram during menses, this all will lead to retrograde menses going to the tube and causing implantation to other area. Now, this also, the retrograde menses can be because of nulliparity, because nulliparity they are not they didn't get pregnant, so there is more menses in their life, so that's why they become more susceptible to retrograde flow. Now, during normal delivery, during cesarean section, this also might cause implantation to other areas. Endometriosis is the previous is 10%, and what happened is, imagine that now you have the implantation, okay, to other area. Now, let's say this is the ovary. All right, and then you have the ectopic endometrial tissues is here. Now, if there is menses, remember we are talking about dysmenorrhea. That means associated with menses. So if there is menses, this tissue will respond. So there will be proliferation, there will be bleeding and everything, but they cannot go outside. So they form a cyst called as endometrioma in the ovary, causing, it's known also as a chocolate cyst. Now, this will lead to what? This will lead to inflammatory cells release, and then will cause pain. This is number one. This is why we have pain. Number two is there will be fibrosis. With time, there will be fibrosis, okay? And this fibrosis can occur in the tube or here, causing infertility, or this fibrosis can occur in the recto, let's say anywhere. If they depend where is the location of the endometrial ectopic endometrial cells. So if you see here, we will have the extra cells found in the ovary will cause endometrioma, and they will cause cyclic menses pain, and then you will have the other area if they go to the tube or they go to the rectovaginal pouch, and all of this will cause, depend on the location. I'll tell you now. Now, if you have the ectopic endometrial tissue in the rectovaginal pouch, this is not rectouterine pouch. It's not nice. Why? Because it can cause dyspareunia, dyschezia. It can cause severe dysmenorrhea, very severe one. Now, ectopic endometrial in the bladder will cause the urinary symptoms. Okay. Okay, so this is the pathogenesis. Now we take up the risk factor, and now this is how you look at the laparoscope. Now remember, endometriosis you cannot diagnose it by anything except during laparoscopy, and this is not a pre-malignant condition. Now you have mulberry spots, you have uh, the powder, something called as a powder, something in the peritoneum. Okay. Um, it's called the powder burn in the peritoneum. Okay. Now the location, this is the ovary, and here you can see it in the tube causing infertility. This is in the rectovaginal pouch, and this is in the uterosacral ligament causing nodule and severe dysmenorrhea and dyspareunia. Now, here you can see the signs and symptoms. Now the symptoms, dysmenorrhea, dyspareunia, dyschasia, so depend on the area. And remember that they are not characterized by menorrhagia, but they have spotting in between the menses and severe pain before and during the menses for the first few days. Now, the signs are cervical motion tenderness. You will have ovarian adnextic mass, and then you have the fixed retroverted uterus. Now, you know that the uterus has two, anteverted and retroverted. This is anteverted, which is normal. Retroverted will be like that. So, because there is a fibrosis in the cul-de-sac or rectovaginal pouch. Now, there will be painful PR examination. So you need to differentiate it between ectopic and appendicitis, because both of them, they will cause painful PR examination. And they will see the nodularity. Now, investigation, CBC ultrasound, just to exclude the other conditions, and you have the laparoscope. Now, the management, the main aim is to decrease the menses. So accordingly, you will manage. So you can give medical treatment, contraceptive, because as I mentioned, you want to decrease the menses, or decrease the pain, non-steroid anti-inflammatory drug, or giving other drugs as gonadotropin-releasing hormone analogs and androgen derivative, because they will inhibit FSH-LH. Now, conservative, you can imagine that she wants to become fertile. So what you will do, you do laparoscope, you will remove the fibrosis, and then you will do IVF if it's not helped. The aggressive surgical, now imagine that a woman, she's very old, and then she have massive adhesion. You cannot treat it, and she have a chronic pain. In this case, you will advise her to go total abdominal hysterectomy and bilateral salvage or oophorectomy. Now remember that here you have to be careful. You have too much adhesion, so there is a risk of intestinal or the bowel perforation, and the bladder also. So you need to do cystoscopy. You need to give enema to prevent the risk of sepsis and perforation of the bowel and the damage to other areas. So you need to be careful. So this is all about dysmenorrhea, and thank you.